Okay. Okay, how do you turn that off, Christy? I don't know what that means. Back to that. Okay. For everybody that's on, thanks for joining us. Thanks for joining us early. We're still figuring out buttons, but we'll get this started on time as best possible. Cool. There she is. Okay, folks, it is 10 sharp, at least on my clock. I'm going to wait one more minute just to see if anyone's going to get on the webinar. Okay, I'm going to stop sharing my introductory slides. Okay. Oops. And then Caitlin, go ahead and bring your slides up.
All right.
So guys, it's 10:01. So with respect to everyone's time, I'm going to get started. Welcome to our live Wednesday webinars presented by SSM Health Cardinal Glennon Children's Hospital here in St. Louis. I am Terry Kuehler. I'm a pediatric outreach educator. And again, I continue to appreciate and thank you guys for supporting our live programs. Today's program is Child Life for EMS and community hospitals. I've been very fortunate in my career to have access to child life therapists in my practice, and I've grown to more and more appreciative of what they do every day. This is going to be presented by Caitlin Vasquez. She is a certified child life therapist since 2011, and she's also a certified infant massage instructor since 2016, something that I personally grew to appreciate. Also, being an old neonatal ICU nurse, and I know the magic that they perform for even those little guys. She did receive her bachelor's from St. Louis University and her master's from Indiana University, Purdue University of Indianapolis. She's experienced in working in emergency departments in Alabama, Kentucky, and she's currently here at Cardinal Glennon. She is adjunct faculty. She's been adjunct faculty at multiple institutions, most recently in Maryville University across the river. She has presented at the Southeast Child Life Conference and the Midwest Child Life Conferences, both on pain management. So I'm going to be quiet. If you guys would just double check that your mics are muted. If you want to be on camera, we are videoing this. So if you want to be part on camera, just feel free and leave your camera on. If you would, Forrest, put your questions in the chat room, which I'll address. And I'll address those questions at the end of the presentation. And at the end, too, feel free and ask your questions live. Again, your surveys, if you would, I'll give you 10 days to complete those. There will be a link and a QR code in the chat box for those. And again, I'll get those out hopefully within a week. So without further ado, I'm going to be quiet and let Caitlin take over.
Thank you, Terry. Thank you all for spending an hour of your time with us this morning. I know the weather out there is beautiful, and if you're not at work or at school, you'd probably rather be outside. So today we're just going to cover some tips and tricks working with those pediatric patients. It's my understanding that the majority of people on the webinar are nurses and mostly in community hospitals. I know we might have some medics. Most of the things that I'll say will be kind of specific to hospitals, but it's going to be applicable. IVs are obviously done anywhere else. This is a webinar format, so definitely if you have questions, please type them in the chat box. Terry can let me know when they pop up, as I'm not able to see those right now. This is a conversation that we usually have more in classrooms and more interactive, so please don't hesitate to ask those questions. So without being over the top, basically when we see this come through our doors, it's really hard to internally kind of not to feel the same. So the goal of today is to give you some tips for how to make these interactions with these tiniest patients more successful. There still might be tears, but if you can come out of it and get everything accomplished and the parents be understanding, that's usually a huge help. So our learning objectives, it's just kind of the brief outline of what we're going to go through today. These will be evident on every slide, but we're going to talk about the importance of building truth and trust with our pediatric patients. Kind of sounds like going back to basics, but those littlest patients, we kind of have to earn their trust pretty quickly. The next thing we're going to cover is the importance of the language that we use with our pediatric patients. We don't talk to all of our adult patients in the same manner. Our pediatric patients kind of have this whole other language that sometimes can seem kind of foreign. We'll also talk about different ways to position our pediatric patients to make our interventions go more successful. And then we'll talk a little bit about distraction techniques that we can use to kind of remove their focus from whatever scary thing is going on. So Terry mentioned I'm a child life specialist. Briefly, what is child life? I think that if people say nurse or respiratory therapist or MA, all these things are kind of well known. Child life is still a little bit of a trickier job to describe to people. The Association of Child Life has this big, long explanation of what we do if you feel like reading all of that. But basically, our job is to provide psychosocial support to pediatric patients and their families. Typically, this is in a hospital setting, inpatient or outpatient. Most of my time has been spent in the ER. That's where I think a lot of you guys are based out of, or at least doing that intervention side of things. So it's our job to decrease anxiety. So I'm going to give you guys some different things that we think about when we are trying to accomplish this ourselves. If you're lucky enough to work in a hospital that has child life as your resource, if you walk into the room and the child's under the chair, you can immediately leave and call child life and we will get them out from underneath the chair, ideally. If you are working out in the community, we will talk about some things to kind of think about that are going through that kid's brain and kind of ways to work around that. So the first thing we're going to talk about is how important it is to tell the truth when speaking to pediatric patients. It sounds really basic, kind of that golden rule, but we're going to go back to that. We want to be honest with our patients with this population in particular. You don't lie to your adult patients either, most likely. As adults, we don't like surprises from our medical providers. It leaves us feeling overwhelmed. It leaves us feeling anxious. We kind of feel in the dark and uneasy. As kids, this is heightened. When they come into this new foreign environment, they're already anxious. And then if they think that we are tricking them or not telling them the truth, they're going to be even more anxious. The goal of telling the truth is to make sure that our pediatric patients feel safe. Adults want to feel safe as much as we can. Same with our littlest patients. Also, by telling the truth, it kind of puts that as an example for parents. Believe it or not, every once in a while when parents bring their kids into the hospital, whether it be for a surgery or maybe for an emergency visit, they don't always tell the truth to their kids. So it's our job to kind of lead by example with that. I've typically am in the ER. I've worked in the OR as well, and I've had a child tell me that they were here because their parents were bringing them for a treat at the hospital. Surgery is not a treat. So just kind of leading by example and telling the truth. It also is going to kind of set us up for success, right? If they trust us, they are going to listen to us and actually understand what we're saying, hopefully. Even outside of the hospital, just kind of to harp on this a little bit more, if somebody tricks you, it's going to take a lot to earn their trust back. And you don't have time in the hospital, right? If you give one medication, you say it tastes like grape and it tastes absolutely terrible, the next thing you come in to do and you tell them, they're probably not going to believe you. So again, it just is detrimental to the goal of care if we're not telling the truth. We want children to trust us for the duration of that visit, like I said, but we also want them to trust medical providers moving forward. Kind of an extreme example, if you have a child coming in, they get a new diagnosis of diabetes or whatever it might be, they have to keep coming back. So you want them to trust that whoever is taking care of them is there to help them and telling them the truth. If you're an outpatient lab, or even if you're in just a pediatrician office, they want to know that when they come there, they're safe. Kind of an aside with that, speaking of leading by example, it's really important to verbalize that as medical providers, we're here to help them. We're not the mean doctor, the mean nurse, the mean medic who's, poking you with things. We're doing X, Y, Z to help you feel better. Sometimes that can go opposite of what caregivers are doing. They might say, who hurt you or who did this? And, actually, Nurse Susan did this because she's trying to help you feel better, or, we're here to fix your arm or whatever it might be. The phrase no surprises kind of speaks volumes to kids. So that's kind of one that to put in your back pocket there. There's no surprises while you're at the hospital. And then going back to the experience that they're having, if they're at the hospital or they're in ambulance, they're in a novel experience that feels completely out of their control. So we want to give them a little bit of that control back by giving them choices. I know that sounds really hard, but there are itty bitty choices that you can give them that mean a lot. So if you're starting an IV, do you want us to look at your right arm first or your left arm first? Might not give the choice of do you want it in your right or left, but where do you want us to look first? Give choices, right? Give two. That way if they say no, well, that's not an option, right? No, I don't want you to look at my arms. Well, I can look at your right or your left. Do you want us to count before we do it? Do you want us not to count? Do you want to watch or do you want to look away? That one's a little bit trickier, right? In our gut, we think, oh gosh, they don't need to look. Takes a little bit of an assessment when you're watching them. Some kids really do benefit by seeing what's going on, maybe so they see that you are telling the truth. Not all kids can look. But that being said, closing your eyes or you have to distract them away, which we will get to later on in this conversation. I also like to give a choice with parental involvement. Do you want to hold mom or dad's hand? Do you want them to sit with you? Do you want them to sit by you? In some circumstances, you can give them the option of whether they want to wear the gown or not. For those young school-age patients or that late adolescent group, they don't like to get into the hospital gown. If you can not put them in the gown, I completely would kind of push towards that. If you take the gown out and say, here, I need you to put, our hospital shirt on, and they start to get really nervous, they have to have it. Let's explain why. But if they don't, maybe just not fight that battle because there's probably other ones you have to fight. I will acknowledge that I've worked in hospitals in the past. In Kentucky, where I worked, child abuse is very high in Louisville, and every patient had to be put in a gown just because you never know what you were going to catch. But again, if we can give that option, that's just another one to give them. If you're giving them a popsicle at the end, do you want green or do you want purple, right? Do you want Sprite or water to drink? So another way we're telling the truth is providing some type of preparation before we do something. A lot of times you'll hear child life, particularly in an outpatient setting, in the ER, will say that our job is to tell you what happens before it happens, right? You're back to that no surprises, you're back to building trust. I know that as the nurses, you guys don't have as much time to do this, but you can still acknowledge that you're going to, you're not going to surprise them. You're still going to tell them what's happening before it's going to happen. We like to tell the what and the why, right? So we are giving you an IV so that we can give you medicine. We are going to use our string Band-Aids because the Band-Aids that you have at home aren't strong enough. COVID times, right? We're going to get a booger out of your nose so that we can see why you're sick. So just telling the what and the why is kind of your key components for your preparation. One last time, if we're honest, it kind of helps facilitate our success. All right, so moving on, there's a lot that we can say about language. We could probably spend a whole hour on language alone just because we can break it down to that developmental age. But we'll just kind of hit the highlights today. In general, even if they are at just a typical provider visit, if a kid's at the hospital, they are not having a great day full of rainbows and unicorns. But we can help make it less threatening by choosing language that isn't quite as scary. We're not saying things like, oh, we're gonna, first we're gonna poke you with this, or this medicine stings, or it burns, or it hurts. Those are all words that we think about, right? And we think about it before we go in the room. Oh, great, they're gonna hate this medicine, they're gonna spit it out everywhere, or I have to give lidocaine and it burns really bad, right? So we don't want to lie to our pediatric patients, but we want to say words that at least encourage us to go along with it. So we're going to say things like something might feel like a pinch. Our medicine might feel warm or maybe tingly. Something is uncomfortable. You might feel something push or pressure. One of those token lines that you'll hear is some kids say it feels like X, Y, and Z, right? Some kids say this. Sometimes people follow up on that. Well, what did you think? You might get a lot of answers that are pretty intense. So you don't always want to follow up, but just giving them words that are going to set you up, again, to be successful. Sensory cues are also really important for kids. They are of utmost importance with the toddler age and that preschool age. This is how they are processing a big part of the world. We want to talk about things that they are feeling, that they are smelling, that they are hearing, both before they happen and as they happen. So maybe we're talking about the light is really bright. Our medicine is cold. That rubber band is really tight on your arm. The Band-Aids are sticky. They're sticky when they come off. It's just another way to acknowledge what's happening in the room. Another important thing to think about when you are talking to pediatric patients is using those first then statements. These are imperative for children who have autism spectrum disorder or sensory processing disorder because they thrive on routine. But they're also being used more and more in classrooms. I feel like they're kind of like a hot phrase to use the past few years. So maybe first we're going to put this rubber band on your arm and then I'm going to look with my fingers. First we're going to take your temperature and then I'm going to listen to your heart. Right, first we're going to check your weight, then we're going to check your height. Or maybe first we're going to fix your arm and then you can have a popsicle. First we need to do this and then you can leave, right? So whether it's the next step that you're focusing on or kind of that end game that they are focusing on, right? They're ready to leave, especially toddlers. They're ready to leave. They're ready to leave. Bye-bye, bye-bye, right? First this, then bye-bye. We want to choose language that's developmentally appropriate. That kind of means two different things, right? Where they're at in the development is not necessarily where they're at in their age. We kind of think of how we talk to toddlers and how we talk to grade schoolers and how we talk to adolescents as being kind of those three groups. But we want to think about the amount of language that we use, right? How much details are we giving? We talk about the timing of things that we say. You don't want to say something too early to make them super nervous, depending on their age. You don't want to say something right before you do it because they don't have time to process it. So it all kind of depends. We'll come back to this when we talk about some specific examples. Again, we could spend a whole hour on language alone, but I want to kind of keep giving little bits and pieces just to kind of give you a small toolkit to work with. Validation and appropriate praise. So when you provide praise, it really helps with pediatric patients because with kids, we really want to encourage mastery, right? In school, in the healthcare environment, in their hobbies, a big thing is mastery. They want to learn how to do things on their own. They want to feel successful. These things are also imperative to successful child development. So when we give praise, it needs to be specific. A lot of times you just think about, oh, you did such a good job, Johnny, or what a big girl you are, or you're so big. That helps a little bit, but if we really want to encourage their mastery more, if we want to encourage them to continue to doing what they're doing, you need to be specific. So you're doing a great job keeping your arms still. That one lets them know they're mastering the task, but that also makes them keep doing it, right? So you're doing a great job keeping your arm still, even if just we're looking for the IV site and just the tourniquets on. If we remind them how good they're doing at keeping their arm still, hopefully they will keep it there. You're doing a great job following directions. That's acknowledging that they have listened. They are doing the best that they can. We also want to validate their feelings. I want to say feelings that are said and also unsaid. That stoic little boy who is crying those silent tears, acknowledge them, right? Same with the stoic little girl who's crying those tears. I know that the hospital can be scary, but you're doing a good job listening. I know that the hospital is scary, but it's my job to help you. Maybe I know that the hospital is scary, but even adults don't like hospitals or things like that. Just acknowledging even also what they're feeling in terms of not emotional. So I know that rubber band is tight. I know that doesn't feel good or whatever it might be. I know that was cold. I know that medicine didn't taste good. Acknowledging those things so that, again, going back to that truth telling, going back that they can trust you, you're on their team, and you want them to feel better. I typically caution people to stay away from phrases like, you are so brave, you are so strong, you are so tough, kind of do the implications of those things. Culturally, developmentally, also thinking about what got them there, like if it's a traumatic situation. There's just some implications to using those words that I would stay away from those if possible. Another kind of language thing that we think is providing praise and validation is saying you're okay. If you have a patient who you're trying to start an IV on, or I don't know, even they're just there for an ear infection and they're screaming, it's kind of our instinct to try and talk them down, say, you're okay, you're okay, you're okay. 5 adults yelling at you that you're okay does not make you feel okay. If they are that upset, they don't feel okay. We need to give them information so that they can get there. We can say that they're safe. We can say that, mom, dad, aunt, whoever is here with you. But saying you're okay as you're perhaps poking a needle into their arm or whatever it may be, they don't feel okay. Think about, again, as adults, right? If you are having a procedure done, no matter how minor or how major, if somebody's telling you you're okay while you are a little bit beside yourself, you probably aren't going to appreciate it. All right, so check to see where we're at with time here. I know I talk a little bit faster on webinars when we aren't able to see each other and ask questions during. So we'll just kind of keep on working through until we can get to those questions at the end. This poster on the right is different comfort positions. Different hospitals have them posted places, different offices are kind of proponents of some of them and not of others. In general, if you think about going into a medical environment and you have to lay down on your back, you are kind of at unease, right? You kind of feel vulnerable. Kids are the same way, but obviously amplified. If we don't have to do procedures like this with kids, it's better. Using positions of comfort can be hugely successful with many patients. I'm also going to acknowledge that it doesn't work with every patient because of one major factor. Comfort positions take 2 people. Typically, we are using the parent and the child. They are both coming with their own set of coping mechanisms or perhaps lack thereof. Kind of focusing on the parent, they're the caregiver, right? Kids feed off of their parents' anxiety. Parents feed off of their kids' anxiety. If that is not a good dynamic, comfort positions might not be the best, but they could still sit up for their IV in the bed or whatever it may be, just maybe not sitting on mom's lap, dad's lap, whoever it might be. You definitely don't want to start a procedure on mom or dad's lap and have to stop halfway through and start all over again. And that's never, it's not going to work. It just is kind of setting up for failure at that point. There's a couple different examples on this poster. Again, different hospitals will be proponents of different positions. That back to chest, I think, is typically the most successful if you want me to give my honest preference of comfort positioning. Also, as an aside, this is typically with the caregiver, but if the child has developed a great relationship with a staff member for some reason, use that staff member if that staff member is willing. Because if they found a safe person, we want to utilize that to every opportunity we can. So that back to chest, you can secure the patient's legs with the caregiver's legs. So patient sits on mom or dad's lap, and you can do this while they're sitting on a stretcher, or you can do that sitting on the side of the bed. Either one, honestly, on the stretcher is better if you can, because you can get the patient's legs flat. But you use the mom or dad's legs to secure the patient's legs, and then you can stabilize that arm over the patient or caregiver, or over the caregiver's arm. You can also utilize your helper, whoever might have come in with you to do an IV or whatever it might be. IVs are my go-to example because they seem to be the most traumatic and also most likely to happen when they come into the hospital. That center picture talks about using a swaddle. Obviously, this is going to be with our infant patients. An aside is if infants aren't swaddled at home for whatever reason, maybe they truly don't like it, don't swaddle them at the hospital. They're not going to like it there either. They're not going to magically get accustomed to swaddling. That's something that a family typically has started from the beginning. You can't introduce it later on. It's possible to swaddle with leaving that targeted arm, leg, whatever it is that we're working with out and putting everything else in. I know that some people will say, oh, we need to swaddle this kid. It's not a swaddle if it's not swaddle age. It's more of restraints, which we kind of frown upon. Obviously, we want to keep the kid safe as possible, but in a way that they feel safe. So typically, we're going to stop swaddling patients around 2 to 4 months of age. It depends kind of when they start rolling. Kind of aside, since we're talking about infant patients, sweeties, sucrose, whatever it is, toot sweet, whatever it is at the hospital that you're working at, is great for painful procedures. The best way to give it, best practice, is 2 minutes prior to the painful procedure and all throughout. It is not in the quantity that you give. It is when you give it. It's marketed up to 6 months. Studies have shown that around 4 months, it kind of loses its effectiveness. Think about 4 months old, what's happening, right? They're starting to get those different foods, so therefore they're being exposed to some of those sweet things. With any of these, it's really important to ask the caregiver if they want to be involved before you kind of offer it to the child. Because some parents might not feel comfortable holding their child for whatever reason. This chest to back one with the patient sitting facing you, I find that one a little bit more difficult to use. It's really hard to brace the patient's back, and they're kind of able to push back and get a little bit more squirmy. So I think that back to chest seems to be kind of the best option. Sorry, that was chest to chest that I'm not real keen on, but it might work for wherever you are. Again, positions of comfort can be really tricky. They do take an extra minute to work through, but they can be hugely successful.
Hey, Caitlin.
Yes.
Hey, I see that poster is from UC Davis. I mean, is that available online, or is that available to download?
It is, and honestly, okay, I can send a couple out that I have found that we've utilized from other places. Cardinal Gwinnett does have one as well that we might be able to post a link to.
Sure.
Yeah, so
okay.
I know the pictures help of it, but a lot of these positions are in a lot of offices and hospitals already.
Sure.
I always encourage people who are not in healthcare or who are in healthcare who are taking their own patients, children to be patients, to advocate to use these things. It helps their child feel safe. So I've gone to, my child's office and advocated to hold, and with different staff members, it's kind of gotten a little eyebrow raise, but typically once they see it works, it goes along really well. But yes, that the poster is available. Also, if anybody wants to Google it, it's comfort positioning. You'll find something pop up pretty quickly. Another big campaign that has been out for years, has a really good information, is One Voice. So it's an acronym. Each of these letters stands for something really important when working with our pediatric patient. The overarching One Voice idea is that you only need one person talking really calmly to the patient. You don't need a bunch of people talking over each other, right? It starts out this volume and it gets louder and louder and louder as more people are trying to tell this child to calm down. A lot of people screaming at you, or, talking what you feel like is screaming, even though they're not, just because you're nervous, doesn't typically facilitate success. So you want one calm voice. It can be the caregiver. It can be a staff member. One voice. If you're working in a community hospital that does traumas and you get a pediatric patient, typically in our world, one person is speaking up by that child's head and kind of telling him or her what everybody is doing in a more calm manner, as everybody else is kind of rapid fire accomplishing all of their tasks that they need to do quickly. to ensure the child is safe. The next one, need for parental involvement. If possible, don't take this child's safe person away from them. If you want to take the patient and the caregiver to like a treatment room that's not in the room that they are currently in, that helps their current room feel safe. Sometimes we do need to give the caregiver an opportunity to leave the room. That being said, we don't want to take them away, but we want to give them the opportunity. So the mom or dad that's pacing and saying that, you know, this is going to hurt or whatever else, we can give them the opportunity to leave the room just so that it doesn't escalate the situation any more than it probably already is. We want to educate the patient before the procedure. So that's what I talked about, giving preparation, right? If we tell them what's going to happen before it happens, we're developing that trust. We're speaking to them in that developmentally appropriate language. Validating the child with your words, acknowledging what's happening and acknowledging their feelings, being as specific as you can. Again, it promotes mastery, but also promotes us to be successful. Physically position that child for success. We can come back to those if you guys have questions about how exactly they work. I did talk about IVs, but they're great for injections. Comfort positioning works really well for sutures as well. Some of the radiological procedures don't allow it as much, but some of them truthfully do, just depending on how you can kind of work it. We want to individualize our game plan. Not all pediatric patients are the same, just as not all adult patients are the same, right? We wouldn't approach our adult psych patient the same way we would approach our adult pregnant patient. We can't approach our broken arm the same way we approach a kid who's been vomiting for 24 hours. And then obviously taking into other accounts of who's in the room and things like that. But making sure you're going in knowing that this patient is different than the other ones that you've dealt with in the previous rooms. Another thing we're going to talk about is choosing appropriate distraction. I know being out in the community, you're probably not going to have that repertoire of distraction manipulatives that we have in a freestanding children's hospital, but I'm going to talk about a couple of things that you can use. And then the last one is eliminate unnecessary people. Too many people is honestly counterproductive. In my experience, typically you rarely need more than 2 staff members. Obviously, if there's a trauma again, or something, you know, there are procedures that you need a lot of people, but you probably don't need like 4 people to do an IV on a 2-year-old. Lots of people can be really overwhelming. Just recently, as we know, it's kind of the start of the new school year. July 1st is still pretty recent. We had a patient who had a broken arm and we had moved them to a different room to be sedated so that we could reduce. And the kid's like, wow, there's a lot of people in this room, because we had the nurses, we had the attending of the ER, we have the attending of ortho, we have the residents, we have the other residents, we have the med students, right? So there's like 7 people in this room and this kid's just looking around. And he's like, there's a lot of people in here. It's kind of scary, right? So advocating for maybe not all those people to be in there unless they need to be. So in that example, anybody who wasn't needed for the actual induction of sedation just stepped out for like 2 minutes and then they all stepped back in. The kid didn't know that they were there. They could still do their learning, and the kid felt safe as they were starting the procedure. Again, that's going to facilitate your success. So just having a lot of people is really counterproductive, and it kind of goes back to individualizing that game plan. If we know who's going to be in the room and what their job is, that's going to help facilitate the success. So distraction, like I said, in a pediatric hospital, obviously we have all kinds of things available to us to help these procedures go better. In community hospitals, it's probably a little bit more slim pickings. So I kind of focused on a couple of resources that are low cost but super effective. So my old school example of bubbles, they make those really small bubbles that you can put in your pocket, hang on your badge. Honestly, the best ones are the wedding bubbles at Hobby Lobby that are like $5 for a whole big container of them. Amazon also sells the brightly colored ones. But blowing bubbles is something that tends to work really well, especially with the smaller patients. Obviously, it's a little bit trickier now with COVID. So depending on the precautions that are in place at your hospital, you might have to get creative. Bubble guns are going to obviously be more expensive, or bubble blowers are going to be more expensive than the small bubbles. But depending on how the room is laid out, you can still kind of make that work. That second picture is a picture just to resemble those I Spy. We've all seen I Spy books from when we were younger. Couple ways to go out this. You can get just one book for your hospital and tear out the pages and laminate them. That way you can wipe them down, take them from room to room. That way they're also big enough to block the view. The purpose of distraction is to give them something else to look at, whether that is taking their attention away from what's going on so they can look back and forth between the two, or maybe it's a super anxious kid and you need to block whatever's going on so they can't see it. That's really good for that, like just book size piece of paper for an I Spy. You can also make your own I Spy. So take just whatever's in the drawer at home, bunch of toys, like that's got screwdrivers and keys and a little stopwatch, some balloons. Arrange it, take a picture. Obviously, I'm going to go back to Google Images. If you Google I Spy, something like that will come right up. I have had one of those hanging on my badge, the same one since actually my internship. It's just a little laminated card. So it doesn't have to be big. The good thing with the I Spy is it can work for a lot of ages, right? So we can ask about colors, we can ask about characters, we can have them count how many of whatever object that they actually see. Depending on the procedure, they might be able to point to it or maybe not, right? If it's a fracture reduction, we have one broken arm, we'll put an IV in the other one. We can make it more of a verbal I Spy game. It can be patient-led or staff-led. You can see if they want to find something for you to find or if they want you to tell them what to find. A couple different ways to do it, but again, it's taking all these things are to take away the focus of what's going on. That third image is just one of those little plastic magic wands. They make the small ones that are like the size of a pencil that you can fit in your pocket. They make the ones that are a little bit bigger, turning those back and forth. Multiple things you can use these multiple ways, right? So we're looking at colors, we're looking at shapes. If it's a wand with 2 colors, we're looking at which color is going to make it to the bottom first. You can use it as a timer, right? By the time this is done, coming to the bottom, we'll be done with whatever it is that we're doing. Kids work really well with knowing how long something is going to last. That last one on the right, those light spinners, all kids are entertained by those, but especially the younger, the better. They sell those itty bitty ones at the Target dollar spot for whatever season it is, right? They always have summer ones, they have winter ones, Valentine's Day, all those different things. Those are great because they fit in your pocket, and believe it or not, those bigger ones are a lot more durable, or the smaller ones are a lot bigger than the smaller ones are a lot more durable than the bigger ones. That picture that I have posted, those are the ones on Amazon for $3.99. They're great. You can wipe them off, you can clean them, but if they hit the ground, they're not going to make it out the other end of that. So depending on, again, cost, depending on where it's being kept, I typically don't leave something like that with a patient because they are going to break. But those little ones that fit in your pocket, whether it's your coat pocket, your scrub pocket in your pants, those are kind of the best way to go with that.
Hey, Caitlin, more weird questions because that's what I ask. Those aren't choking hazards, are they? Just a
No.
Okay,
So,
just making sure.
and they don't have the button batteries either. I know some hospitals don't want anything with button batteries. So, yep, none of those would be choking hazards. And I haven't had any issues with using those smaller bubbles either in rooms. Obviously now with the COVID concerns, it's a little bit different, but in terms of using them, even if we're doing like sutures or doing an IV, you're typically able to still use them and keep the site as clean and sterile as it would be without them.
you.
All those things we just cavi wipe down at the end too. Did you have another one, Terry?
No, I got more at the end as always. So
Perfect. I appreciate it. All right, where are we at with time? 10:40. So we'll just talk through a couple different interventions, kind of those words that we use typically in the pediatric world, just to kind of stick in your little toolbox for later. If we're doing an IV, thinking about a school age patient is kind of where we're going to be with this example. But we're going to be testing your blood to figure out why you're sick, or maybe we're giving you a small medicine straw so that you don't have to taste that yucky medicine, or you have a broken arm, and if we give you medicine through this small medicine straw, it's going to work quicker than if you had to take medicine like you do at home. Typically, I allow patients to feel an IV catheter. I'll put one in my pocket for that shift, or I'll just pull one out in that room and get another one for the next room. Again, resources, they can be cleaned. If I don't have one in my pocket, I will loop one through my badge to use for that day. You'd be surprised the amount of adults think that if you have an IV, there's still a needle in your arm. It's happened at 2 different hospitals where I had an IV catheter hanging from my badge, and somebody's like, "You have a needle on you." No, I don't, and this is why children are scared. So letting them feel that small straw that we're using, small enough for a mouse to drink out of, it's bendy, things like that. I'll say that we're going to use our blue, orange, whatever color rubber band. Typically, I'll say that, we're going to tie it over your shirt so that it doesn't pinch your skin, if that's an option. Sometimes a lot of nurses will take the extra time to, put one of the paper towels over their skin and tie the tourniquet over top of that. For those sensory kids, that's really important. For other kids, it doesn't make a difference. But if they start to talk about it pinching, if you can put some type of cloth underneath, it seems to make all the difference, or at least make them think it is. So we're going to use our blue or orange rubber band. We're going to look for our best blue lines, our veins, depending on the age. Then I talk about our cold, stinky soap. Again, we're providing all those sensory cues. If you are in a community hospital, you more than likely are not able to numb for an IV. So I talk about it being a quick pinch. When I used to work in hospitals in the South, they compared it to an ant bite a lot. Say it up here and nobody knows really what that feels like. But I'll say like a quick pinch that doesn't feel as bad as when your siblings pinch you. I talk about the Band-Aids or tape. Kind of as a side note, the Band-Aids and tape, right, when you put that tegaderm on, that's when the procedure is over, not after the IV is inserted. If you insert your IV and you get flashed and you say, we're done, well, you're not done because you're still there pushing and touching and everybody's still around the child. So you're done after the Band-Aids, the tegaderm, the stickers are all put on. You can say the hard part's over. We just have to finish with our Band-Aids. A lot of times, those pediatric patients are going to say, "You're taking my blood," even after you talk about it, or "What are you going to do with our blood?" Right? We talk about how their body is constantly making more, and did they know that? In IV with the toddlers, your main focus is kind of distracting and then giving those sensory cues, right? So you're acknowledging, you're validating what's going on, and then you're bringing it back. Also making sure that those toddlers feel safe. So mom or dad is right here. Mom or dad is holding you. Do you feel, used to holding mom's hand, dad's hand, whatever it is. Sutures, again, sutures, stitches, words like that kind of have that more threatening mindset to them with children for some reason. So we say string Band-Aids in the hospital. Just like your laces hold your shoes together, these strings are going to hold your cut together. If you have the opportunity to show them the needle drivers, we call them our clickers, right? When you put them together, it makes that noise, thinking about our sensory cues. But if you can, show them that they are not sharp, they don't cut, they just hold our string. Our string is really tiny. We have to have it to help tie our knots. I let them see and feel the string. Again, the suture, if you're able to, that's great. Not the needle. You cut the needle off. Believe it or not, in 11 years, I've only had 3 people actually see, like at the end after the procedure, asked to see actually what the needle looked like. When you're talking through these things, typically kids are going to hear what you say and know that they're numbed and whatever it may be. So where they don't ask to see that needle, or if they do, I say, we'll show you that to you at the end so that your mind doesn't play tricks on you. That's another kind of phrase that we like to use a lot. You can watch something, but as long as your mind doesn't stay tricks on you so that you're still able to be still. After they are numbed, I talk about how the strings feel. You're going to feel them push and you're going to feel that string wiggle. Again, the lidocaine feels warm. It might feel hot. I don't really like to say sting or burn. I like to focus on how that's the hardest part and that it only lasts for X amount of time. So depending on the cut, it's going to last as long as a commercial. For those that still watch commercials, or it's going to last until we count to whatever it may be, since a lot of kids don't see commercials anymore. Other popular procedures, maybe staples. We call those skin clips. As long as it's numb, I talked about that it feels like we're pushing on a bruise. Staples always seem to make parents really anxious, but they're used a lot, obviously, on the head for lacerations. I typically tell the parents that typically, as long as it's a small cut, by the time that first tear falls, the procedure's already over. That's kind of the bonus to staples. They look scary, but they are so quick. If a kid's going for a CT, for little kids, we call that our donut camera. Nothing touches you, nothing hurts. It has a light that goes around really fast. See if you can find the light. If you're talking to a patient about an LP, they've typically had an IV already. So we've talked about how we use that little straw to get some of your blood out. We're going to use a different kind of tube in your back to run another test to help us get information. That was a lot of information, probably a little quick. So what questions does everybody have where I can hopefully provide maybe some more specific answers for you?
So guys, chat room's open if you've got questions. God, should I start? Sure, I'll start. Caitlin, you talked about your experience in the OR. I know a lot of our little community hospitals are starting to do more and more, mainly tubes, ENT tubes. I mean, in the moment when you've got a surgeon ready to get to work, what can you do in the operating room? And I guess this also stems for our personal, not me personally, but I saw an experience where they just mainly, God, they just jumped on the kid, put the mask on, and he's screaming, he's like a 5-year-old, and he was just screaming bloody murder. And me, I felt so bad for him before they started any IVs, anything like that. What can they do in the heat of the moment for something like that?
A couple of different things I think about when you say that example. So a lot of the hospitals, it's weight based on if they are doing gas and they're doing the IV after they are asleep. After they're asleep has its pros and cons. You wake up with it and you don't know what it is. But also something as simple as getting a pack of stickers and decorating that mask, letting them hold that mask on their face beforehand, telling them that medicine sometimes smells like Sharpies, right? So your job is to make sure you take big breaths and blow it away. If they're going to blow something away, they still have to breathe in really big to blow it out. So theoretically, that's going to increase how well it works as well. Obviously, it's going to take a lot more conversations to be able to bring parents back into rooms and things like that. But more and more often, parents are allowed to kind of transition back to the OR, which is really helpful. But decorating the mask is something that's really easy, and letting them have, again, the mastery. They're able to hold on to it beforehand.
Talked about disposables. I talked about that. Oh, what's your opinion? And I think I know the answer. Papoose boards. I still see a lot of papoose boards sometimes that I bring in. I know that EMS, and it's easy to transport with a kid on a papoose board, but again, just wanted any further input about them.
Wholeheartedly against them. I understand that we have to keep kids safe, and sometimes EMS in the field, things have to move really quickly. So that might be their only option. But in the hospital, I don't feel like it is our only option. I know that as child life, one of our biggest things is to educate against that or away from that. If there's child life on the unit, typically papoosing isn't happening. There's other ways to help keep them still, right? That comfort positioning with parents holding them, talking about keeping them safe, giving them that option. Can you hold your arm still, or do you need somebody to help hold your arm still? Acknowledging what behavior is appropriate too. I know you're scared, but you can't kick. That's not, that's not something that we do here, things like that. And then depending on the procedure, sometimes a little pre-med goes a long way. Those anxiolytic drugs do kind of help take the edge off to where it's not a sedation, you're not requiring more resources, but you also are making it easier for everyone involved. And they're also taking away that memory for them as well. So.
I got a question in the chat box that says, "Hi, I'm majoring in social work and minoring in psychology. What would you recommend for me to do to become a child life therapist?" This is from a student.
The quick answer is if you go to childlife.org, you will be able to find a couple specific courses. Having psychology and having social work, you're going to get a lot of those child development classes that you need. But one that you might not be getting is you have to have one that's taught by a child life specialist. And in order to become child life, you have to have certain coursework before you do your internship. And in order to do your internship, after that, you can get certified. So Child Life has a national certification exam that we all have to sit for, and then keep up with our continuing education credits, like anyone else in the medical field. Whoever that is, I can definitely answer more questions if I need, if they have them.
This is Jennifer in Carbondale. I just wanted to tack on to what you said, Caitlin, about involving your parents, giving them choices and options. But from personal experience and as a pediatric nurse, it's also important to find out what they've done to prepare their children ahead of time. So if they're bringing them to the emergency room or they have a scheduled procedure or surgery, because as a healthcare worker, you don't want to contradict what they've already done to prepare their child. So for an example, when my son was 4, he had his tonsils and adenoids out, and I had him all prepared and he knew what was going to happen. We went to our pre-anesthesia appointment. The staff told him he was going to go on a spaceship and get space gas and fly to the moon.
Oh, gosh.
But they wouldn't stop their story. So when he woke up from anesthesia and saw where he was, he would not talk to me for like 3 days because he did not get to go to the moon.
He didn't go to the moon. Yeah.
And
fair point.
And then we had a summer where we were in the ER or urgent care like 4 times for stitches with him when he was like 7. And one time in the ER, his laceration was underneath his pinky toe, and the way the provider had him positioned, he couldn't see where he needed to put the sutures, and he wasn't numb enough because we had already been there twice to get stitches. So he kept insisting that my son was just being uncooperative, and I finally had to put a stop to it and say, let me tell you our story, and obviously he's feeling what you're doing, and let's put him in a position where you can see what you're trying to suture. So I think involving families and eliciting what they've already done is an important part of being successful with your care with kids as well. So
absolutely. The parents know their kids better than us. They're kind of the expert on their kids. So using the parents for your guidance is huge.
And I think educating our families too, because I've been in so many situations where the families make the healthcare worker the bad guy. If you don't behave, the nurse is going to give you a shot. If you don't do this, a negative consequence. So if you're experiencing that scenario, taking time in a private way so the kid's not hearing the conversation, to have that conversation with those family members or caregivers to say, this is just making that situation worse, and what can we do to make this a successful situation? So
definitely. And I've even privately is probably a good way to do it. But I've even said, I've heard them say, well, if you're not doing this, she's going to give you a shot. And I was like, actually, that's not why we give shots. We give shots to help kids feel better. And, shots are not ever going to be because you're in trouble.
Jennifer, thanks for sharing.
You're welcome. I appreciate this. It was a great presentation.
Thank you.
Guys, any other questions? Anything for Caitlin?
I do actually. What is your kind of go-to whenever it comes to removing sutures? We've been seeing a lot of kiddos, including my own child, who's had to have her sutures removed, and it's like traumatizing for them because they had felt the pain of the lidocaine. So whenever they go to get their sutures out, they feel like it's going to be the same way. And I mean, it took 5 people to hold my own daughter down, trying to, explain that, this isn't going to hurt like it did whenever the stitches went in, initially. So what would you recommend on doing that?
I would focus on how that string feels, like when we touch it, right? So if we, kind of the same way when I talk about at the end of an IV, typically, even if it's gone well, they're still nervous at the end. So I let them, do you feel this when I touch the end of this? Does this hurt? If you can take a minute to show them that we're just going to cut the string. So watch my tweezers. Do my tweezers hurt? Here's me holding the string. Do you feel this? Letting them kind of touch the string and realize it's not the string that hurts, and we're only cutting the string. But obviously, that lidocaine moment makes it really challenging. So if we focus on, it's kind of two-tone, right? If we focus on that being the hardest part when we get our sutures in, and that before they leave the hospital, after them, saying that when we take these out, it doesn't hurt, kind of setting them up for that as well. That's not a miraculous answer that's going to make it all better, but just focusing on that when we touch those strings and we're only touching them and we're only cutting the strings, that should help a little bit.
Thank you for that. I just didn't know, didn't know if you had a little bit more experience with that, just because, some do okay, but like I said, my own daughter, it was so traumatizing. So
yeah.
We used to have a doll at another hospital that I worked at that we would actually put sutures in and then let the kids take the sutures out of that doll so they could understand the process. And that seemed to help a lot too. So you can go to Walmart, buy like a little plush stuffed animal and use yarn to make your sutures, and then give them safety scissors and let them practice taking it out before you actually go to do that procedure. And I've had a lot of success with that too.
Definitely. And if you're lucky enough to still be able to do that, that's amazing. I know with COVID, again, a lot of the things that we're able to take in rooms now has been decreasing significantly. But yeah, that example that she just gave gives them that mastery back.
Guys, any other questions? I'm going to attempt to share something. Okay. Oh, wait a minute. There I am, I think. Guys, this is a quick poster that we've got that actually Child Life developed. If you'd want a copy, happy to send it out to you. Just let me know. Again, just something that we've got available. If you'd like one, again, any other questions, you guys? Share. Eek. And start these. Okay. There are I hear my noise. I hear my voice. Again, thanks for joining us. That's okay. Thanks for joining us. I've got the QR code for the survey. I've also got the link for the survey. Give you 10 days to finish that if you would, and I'll get some CEU certificates, and I need to make this slower so it's not rotating so fast. Again, in August, Lori Winkler from our injury prevention program will be presenting on back to school injuries, just because it's the time for school. September, I'm working on for Christmas. Come back here. For Christmas, right before Thanksgiving, I've got a case study about a button battery being ingested. And then for December, we're going to do a review of our case 360. Caitlin, you are amazing. Now the chat room. Okay. Again, people, just let me know who wants me. If I don't get one to you, again, CG Outreach at ssmhealth.com is another way to get a hold of us to get one of those posters to you guys. Again, any other? Oop, let me get these slides back up. Go ahead.
This is Kelly, Caitlin. I just want to say thank you. So before your lecture, as being an adult ER nurse previously, I made a list of questions that I knew I would have, and you literally answered every single question on my list. So I think this is a great presentation and great for our outside hospitals and our outside providers to answer questions. I have Madison's contact information. I just sent, or your contact information. I just sent it to her, so she may be contacting you about some more questions. So
good.
Thank you, dear.
All right, no problem. Thank you, everyone.
I'm taking down names to get the poster too. Again, Caitlin. Oop, Robert, I'll send you one too. Okay. Guys, again, I think it's 11 sharp, so I'm going to stop. Again, we'll stay online for a little bit longer. Again, thanks again, you guys, for supporting this. For supporting our programs. I really appreciate it. Again, guys, stay safe. Back to school is coming. And again, you guys have a good day. The guy from Granite. Yeah, that's probably a better idea. I like that. Oh, one.
All right. Well, thank you, Terry, for helping facilitate this.
Oh my gosh, amazing! Thank you. Again, answered. Oh no, spot on.
Okay. Hopefully, I wasn't talking a million miles a minute. So.
Not at all. No, you're well. And it seems, at least for this one and the one we did in June, we're starting to get a lot more questions.
Great. That's
again,
really helpful.
Yeah, we try to allow we're not sure how long to anticipate for questions. And so I might as well the 15 minutes, 10 minutes, but it seems to be more and more.
Yeah, I thought there'd be more room for questions because I was worried I would get through everything too fast. So it seemed to be a good balance.
Then once I start opening my big mouth, I like to think people think it's okay to engage.
You're right. Yeah.
But yeah, oh my gosh, this one kid, yeah, they oh my God, there must have been 5 of them to hold down to put a mask on. I'm like mortified, and I'm like, you can't do that.
I know. I had experience in the OR in Chicago when I was an intern in Chicago, and we had a little girl who had Down syndrome, and it was summer, right? So a bunch of ready to learn staff, we'll say that, because we were all there. And I remember just getting up. I just walked right in the OR and got up on the table with her because I was in the OR scrubs, and the resident was like, what are you, can she, and the anesthesiologist is like, this seems to be working. Do you really want her to not sit up there with her right now?
Right. Well, that in these small communities have been, not that they have impatient surgeons, but, they're like, okay, I've got something to do. And
absolutely.
Like they want to get the case done, and I get it.
Right.
But anyway, so thanks for addressing that question. But
absolutely.
It's 4. Okay. Am I still? Can I stop recording? Let me hit the button.
Good. Yeah,
okay.
Maybe.
Stop recording. Okay.
We have a hospital in